Doctors with disabilities exist in small but measurable numbers. How did they navigate their journey? What were the challenges? What are the benefits to patients and to their peers? What can we learn from their experiences? My name is Lisa Meeks, and I'm thrilled to bring you the Docs with Disabilities podcast. Join me as I interview docs, nurses, psychologists, OTs, PTs, pharmacists, dentists, and the list goes on. I'll also be interviewing the researchers and policymakers that ensure medicine remains an equal opportunity profession. Welcome to our 100th episode. We're deeply grateful for each of you who have been with us throughout this journey. Your support and engagement have made this milestone possible, and we couldn't be more thankful. Today, we're focusing on a topic close to our hearts, the well-being of our future physicians. Burnout and mental health challenges are real, and it's more important than ever to address them. The power of sharing stories like those we've heard throughout our podcast have shown us how these experiences resonate, inspire change, and build community. We're honored to have incredible leaders with us today who are at the forefront of this important work. Dr. David J. Skorton, President and CEO of the AAMC, has been a passionate advocate for improving mental health and well-being in medical education. Amy Adams, Director of Student Affairs, Alignment, and Holistic Review at AAMC, is leading efforts to create more inclusive and supportive environments for all of our students. And Mytien Nguyen, a researcher and MD PhD student at Yale, whose work focuses on the unique challenges faced by students with intersecting identities, brings critical insights to our discussion from both the personal and professional lens. Thank you so much for joining us on this special episode. Your commitment to listening, learning, and growing with us makes a real difference. Here's to many more conversations that matter. And now, on to our panel. Thank you for joining us today, and we are looking forward to engaging in an enlightening discussion. I do want to say very quickly that we have agreed before we started recording that we are all more comfortable with first names. So hence the David versus Dr. Skorton. Welcome, David.
Thanks so much, Lisa. It's great to be with you, and congratulations on your podcast and all the stuff you're doing. It's important, it's getting more important, and you're making a big difference. Thanks for letting me spend some time with you.
Thank you so much. That means a lot coming from you. I've enjoyed our collaborations over the last several years. So I'm going to start with a question. Can you share your perspective on the current state of burnout and well-being in medical education for all learners?
So well-being among learners, medical students, residents, fellows, it's an incredibly important and a long-standing issue. This has been going on. That is an issue that we have to be concerned about and we have to be better at paying attention to for a very long time. COVID-19 pandemic, of course, exacerbated and highlighted the problem, which continues today. Many medical students started school or clinical rotations right during the height of the pandemic while preparing and applying for residency and dealing with all of that pressure and angst. And residents, like all healthcare workers, face just enormous pressure to care for patients with an unknown and lethal illness while working long hours and putting not only themselves, but their loved ones at risk. And of course, these concerns about well-being, as I mentioned, were before the pandemic and are not just about the pandemic. We know more generally from a lot of research that learners enter medical school with mental health similar to that of their peers, but during med school, their rates of mental health issues increase. Many experience burnout, characterized by emotional exhaustion, depersonalization, and a dwindling sense of accomplishment. And this is due to a variety of factors. Of course, the academic pressure, the workload, the financial burdens due to student loans, and for some, the financial burdens of supporting their families and loved ones beyond their own education, the politicization of the healthcare system, and the constant struggle for work-life balance, which is very, very hard in the medical profession in general, especially for learners. As I travel around the country and have the privilege of hearing from learners and learning from them, I've also heard learners describe particularly severe imposter syndrome. I can absolutely understand this, and I personally have had feelings of imposter syndrome myself at various times in my own training and even later. Now, learners may also develop other comorbid mental health conditions, and that's as a consequence of burnout. One study found that more than 1 in 10 med students have experienced thoughts of suicide during their training. It's a shocking and frightening number. And it reported a strong association between burnout severity on the one hand and suicidal ideation on the other, even when accounting for the confounding factor of depression. Now, when I was president of Cornell University, one year we had 6 student suicides, and I had to reassess my own thinking about this. And although not specific to medical students and residents, this was really heart-wrenching and motivated me to do everything I could to be available emotionally and intellectually to learners. And one thing that I think is very important, that one of my heroes, Daryl Kirch, my predecessor as president of the AAMC, in 2021 in our journal Academic Medicine, he wrote a very moving, I guess I'd call it a short memoir, of his own lifelong mental health struggles. I too have had such struggles and have benefited from counseling. And as I shared with the learners at Cornell, and as I share with learners right now as I travel around the country, asking for help beyond any stigma that's there, and it's still a lot of stigma, asking for help is not a sign of weakness. It's a sign of strength. It's a sign that one wants to go on participating and contributing. Now, we have a long, long way to go, Lisa, to do something about this. We need to educate, prepare, and nurture the future healthcare workforce while safeguarding their own mental health. It's necessary for our learners who enter med school with a passion for medicine, a passion for science, a passion for making the world safer and healthier. But it's also necessary, of course, for the health of our patients and the families and the communities. Healthcare provider burnout, that is beyond the stage of learner, impacts patient care directly. Physicians who experience burnout are more than twice as likely to be involved with patient safety incidents than physicians who are not experiencing it. And it also has troubling implications for our nation's healthcare costs and, of course, for health equity. We need to care for our healthcare workers if we want to have a healthy country. It's another example of the importance of caring for each other. And somehow, despite all the pressures and the bravado of healthcare, of personalizing the experience of becoming a physician, we've all been there. We're all on a journey, all of us.
David's insights resonate deeply, especially when he highlights the challenges our trainees face, including burnout, depression, imposter syndrome, and financial strain. Addressing these issues requires collective action across all levels, including the involvement of medical associations. So I asked David, what is the AAMC's role in helping to mitigate these challenges?
So we were, as an organization, the AAMC, an early participant in the National Academy of Medicine's Action Collaborative on Clinician Well-Being and Resilience. This Action Collaborative on Clinician Well-Being and Resilience is a network of not only individuals, but a network of organizations dedicated to promoting clinician well-being across all career stages, across all specialties. The goals of the collaborative are to raise the visibility of clinician anxiety, burnout, depression, stress, suicidal ideation, and suicide, to improve understanding of challenges to clinician well-being, and of course to advance evidence-based multidisciplinary solutions to improve patient care by caring for the caregiver. Now, we also endorsed the Dr. Lorna Breen Healthcare Provider Protection Reauthorization Act. This bill is named after Dr. Lorna Breen, an emergency room physician at a hospital that was part of the New York Presbyterian family, and that's a system that I saw patients in when I was at Cornell. And she was an emergency room physician who tragically died by suicide in April of 2020. Her story sparked discussions on mental health in the medical field, especially as healthcare workers faced increasing pressure, as I mentioned earlier, as a result of the COVID-19 pandemic. In Dr. Breen's honor, a law was passed in 2022 to promote mental health support and reduce burnout among healthcare professionals. We at the AAMC endorsed the Lorna Breen legislation in 2022 and again this year so that we could continue grants programs for another 5 years. And as part of Action Plan 4 of the AAMC strategic plan, and that action plan is increasing the diversity of medical school applicants and matriculants, we have launched a partnership with something called the Steve Fund. And this nonprofit is dedicated to supporting the mental health and emotional well-being of young people of color and to develop resources to help medical schools better support mental health, with an emphasis on those who are underrepresented in medicine.
And I just wanted to note that the AAMC has partnered with them to co-develop resources to help medical schools provide culturally responsive support for student mental health, and particularly encourage anyone who's listening to watch the webinar that we released last September titled Culturally Responsive Support for Medical Student Mental Health. That's a free and available resource for everybody.
The AAMC has a wealth of resources related to well-being, including support lines so that you know you're not alone when something like this may happen. Articles, research, conferences, as you mentioned, programs, courses. And I encourage listeners to explore this at aamc.org, aamc.org/wellbeing. These many resources we think can help spread awareness, reduce stigma, and connect learners with the support that we all need.
Next, we focus on traditionally underrepresented and marginalized groups in medicine, including individuals with disabilities. I asked Dr. Skorton why it's important to critically evaluate these groups individually when addressing learner well-being.
It's one of the critical questions of our day. Although we need, of course, to be alert to burnout in all learners, not every student, not every resident, not every fellow, and not every physician experiences burnout equally. Medical students and residents who belong to historically marginalized groups, and there's so many of them, women, people of color, people with disabilities, people who are LGBTQ+, people who come from lower income backgrounds, these individuals experience disproportionately higher rates of burnout, period. And these are among the very groups we need in medicine now more than ever. We know that patients are more likely to seek care from providers who share their backgrounds, whatever aspect of their backgrounds. And patient satisfaction and trust is higher with providers who will reflect the patient's own background along whatever dimensions. Having providers, for example, of the same race or ethnicity can lead to better adherence to treatment plans and may improve health outcomes. One study, it was about a year ago, of county-level health data found that on average, and this was related to primary care physicians, who were Black in counties across the United States. The study found that every 10% increase in the representation of Black primary care physicians, every 10% increase was associated with a 30.6 day greater life expectancy among Black people in that county. And the study did not look at which doctors cared for which patients. Simply having a more representative workforce improved the overall county's life expectancy. Very important finding. And as we face a growing physician workforce shortage, I'm concerned that burnout, which nearly half of physicians exiting the workforce cite as the reason they walk away from their practice, will disproportionately harm communities already facing structural barriers to accessing healthcare, impacting not just the physicians themselves, but also the patients and the communities they serve. The chance for equality is achieved when every medical student and resident can bring their full and authentic identity to their medical training, and later, of course, to their patient care. Very important.
Next, we shifted our focus to the experiences of students with disabilities in medical school, discussing how disability inclusion can be a powerful tool for improving well-being. I asked Amy Adams to share how the AAMC is ramping up efforts to support students with disabilities through increased inclusion, highlighting the impact of accommodations on reducing stress and breaking down barriers.
Just like promoting disability inclusion requires medical schools to adopt several different approaches and strategies and structures, it's exactly what the AAMC is doing as well. There's not just one way we're doing this. So one of the things we're doing is trying to keep the topic in front of people through webinars, through conference sessions, dissemination of publications and resources. We're also working hard to make sure that people with disabilities and expertise in disability inclusion are represented on our affinity groups, in our different project and program committees and working groups. We're also always collaborating with experts, including learners, to ensure that culturally responsive, useful, and usable guidance and considerations are shared out with the field. And we're also trying to disseminate that to us internally because we have a lot of learning to do. One of the things the AAMC does best is collect a lot of data. And we are certainly doing that through our student questionnaires to gather that self-reported medical student experience, or do they self-identify as somebody with a disability? What has their experience been if they've requested accommodations, as well as those learner perceptions of the learning environment and experiences with discrimination and bias. But we're also collecting data from our schools about whether or not they're integrating disability content into their curricula, because we know that just as it's important for us to support our learners and trainees with disabilities, it's also important for us to train our current medical students and residents, fellows, as well as practicing physicians on how to provide culturally responsive, high-quality care to patients with disabilities. We're also meeting and collaborating with other organizations such as ACGME, the AMA, the ABC3 initiative, and others to facilitate open conversation and sharing about different strategies. What are effective practices that we're finding? What are challenges and barriers that we're identifying based on where we sit in the ecosystem? And also working to co-develop programming and resources. This is one of many areas in medical education where we're going to do so much better if we're working together rather than try and work in our silos. And related to that, we're also facilitating ongoing conversations between the AAMC's Group on Student Affairs and the NBME about accommodations and many other topics. We're promoting competency-based education and progression. So really focusing on that knowledge, skills, and abilities that learners need to develop and demonstrate in order to, move to the next step, rather than focusing, say, on so much of the how. And I see a connection there with the technical standards. Lisa, you and colleagues, published a great article a few years ago about how a movement to genuine competency-based assessment and progression would kind of obviate the need for technical standards. We're also hosting virtual communities, including the disability community that, Lisa, you were the lead instigator in creating and one of the leading voices in. And these virtual communities, especially the disability inclusion community, is a great safe space where a diverse range of folks from medical schools and other health profession schools can come together. Again, to do a lot of that sharing about effective strategies and practices, but also different challenges that folks might be facing, different barriers their students might be encountering. We also advocate for disability inclusion on the Hill with different federal organizations. Again, that's ultimately more focused on providing that high quality, culturally responsive care for patients with disabilities. But I think it's still really important to mention it here. And then finally, we're turning that critical eye inwards, right? So we're examining our own policies, processes, and practices to see where we might unintentionally have embedded ableism and assumptions in there, and thinking about how we can do better. So how can we think about improving and work on improving accessibility for our in-person and virtual meetings, improving accessibility in our publications, our presentations, and our webinars? And we're being more intentional about consistently naming disability and disability inclusion as essential dimensions of access, diversity, and inclusion.
For some of our listeners, particularly those who are just beginning to welcome students with disabilities, or more accurately, those who are just now seeing students feel safe enough to disclose their disabilities during the admissions and matriculation process, there may be less familiarity with the specific challenges and barriers these students face. So I asked Amy Adams to guide us through the nuances of these barriers, highlighting the areas that need our attention and action.
I want to acknowledge that a lot of the folks who are listening to this podcast are going to be very familiar with these challenges. I also want to note that there's a lot of consistency across work with the report Accessibility, Inclusion, and Action in Medical Education, and the research that your lab and others have been publishing over the past few years. But in terms of challenges and barriers that disabled students have described, they've talked about poor training conditions, including structural, cultural, and climate-related barriers within medical education that make it difficult to fully participate in the learning. They also talk about experiencing disability-related stigma, which we know is very strong. And David, you mentioned this earlier, as well as difficult to navigate support structures. So it's, that question of how useful is a support structure if you can't actually use it. And students have also talked about inaccessible learning conditions and assumptions that all students should learn in prescribed ways. So inflexibility in pedagogy and curriculum, as well as running into unclear and or poorly communicated and designed disability disclosure and accommodations request policies and processes. Students will also talk about, this is kind of my language or our language, but a lack of trained, knowledgeable disability resource providers who are really based at the medical school. And that lack of a designated knowledgeable point person can have a cascading impact of increasing difficulty in requesting and receiving accommodations, not having a safe process or space to disclose a disability, difficulty in identifying or developing appropriate and effective accommodations, especially when it comes to clinical environments. It also can impact or contribute to a lack of confidentiality in the accommodations request process, which then contributes to growing mistrust and lack of safety and belonging, as well as inconsistently implemented accommodations. And disabled students have also talked about long time lags in between requesting accommodations and then actually, going through that process to figure out what the accommodations are, approval and implementation, all of which makes it really difficult to fully participate in learning. Students with disabilities have also talked about receiving insufficient support, as well as just the significant financial and time costs that are associated with obtaining disability documentation, particularly when it comes to requesting accommodations for national standardized exams. students will also talk about just encountering regularly those dominant cultural messages that are rooted in ableism and how difficult it can be to overcome those attitudes and those assumptions that people make.
Amy provided a critical framework for schools to grasp just how broad and pervasive these issues can be for learners, impacting their entire training journey. Academic Medicine just published a new paper from our Docs with Disabilities research team titled, "We Need a Seismic Shift." This paper, led by Dr. Neera Jain, who won a RIME Early Investigator Award for this work, analyzed the largest national data set of disabled medical student perspectives. The study offers fascinating insights into both the positive experiences and the significant barriers these students encounter while navigating program access and inclusion in U.S. medical education. The key takeaway is that it can be done. Some schools are excelling at disability inclusion, but how? And what can we learn from them? I asked Amy Adams, also an author on this paper, to share her thoughts on how we can improve program access and create truly inclusive environments for disabled students.
One of the things we know is that it has to start early. So it's looking at the language and policies and information on our websites and in our other public materials. So what's that public face that we're presenting to current and future students, to current and future faculty and administrators and communities? Are we explicitly integrating disability inclusion into its belongingness statements? Are they directly welcoming and openly welcoming learners and faculty and staff with disabilities into their school communities? It's also about including the experience with and perspectives about disability as part of the experiences, attributes, and mission-aligned factors schools are looking for in their holistic admissions processes, right? We know schools want to learn about the full context of this student, in part because of what a powerful impact that can have on peer-to-peer learning and patient care. Another way that we can further, improve program access and promote inclusion is to designate and hire a trained disability resource professional who works at the medical school, somebody who has the knowledge and the autonomy and authority to design and implement transparent processes and accommodations in collaboration with the learner and the appropriate faculty and staff, and who's knowledgeable about those institutional policies and processes and can really work across the institution. It's also important to think about creating and publicizing those clear policies and processes for disclosing a disability and requesting accommodations, and making sure that you're including this process and policy information in your admissions materials, in your orientation programming, in the student handbook, and to be reinforcing it at key points throughout the year and across the institution. And then it's equally as important to then follow through with that consistent, timely implementation. Another thing schools can do is really focus on building and supporting communities for learners with disabilities and their allies. And medical students with disabilities and chronic illness is a great example of a national organization that's working to form affiliation groups on med school campuses. And we know from speaking with learners with disabilities and the research that building and supporting these communities is really crucial for fostering belonging, for addressing stigma, and for thinking about how to address some of those persistent barriers and challenges, creating a safe space for folks to come, be together, share, just be themselves without fear of othering or stigma. Other things schools can do is provide professional development on ableism, stigma, disability inclusion, universal design for faculty, staff, and learners. Again, there are resources out there through different national organizations. There are resources in MedEd Portal, as well as the expertise in your communities and among your learners, faculty, and staff. It's also important to be calling out and addressing ableism when and where you see it or hear it or experience it, or when somebody tells you about it. It's about building accessibility and disability inclusion into planning. When you're planning orientation, it's ensuring that the activities you're designing are ones that all learners can participate in and are held in physical spaces that all students can access. It's about integrating disability inclusion into belongingness and well-being initiatives and naming disability as a critical dimension of diversity where allowed. It's integrating disability content into curricular and co-curricular efforts. And the Hastings Center actually has a new resource out with principles for disability inclusion in curricula. It's reviewing your policies and your processes for embedded ableism. An example of a great place to start is those technical standards, right? Are you focusing on how learners do something? So, for example, are you saying that a learner needs to be able to speak with the patient or other members of a healthcare team? Or are you focusing on what the student is doing, right? So are they able to effectively communicate with patients and families and other members of a healthcare team? And then finally, it's engaging learners, faculty, and staff, and your patient and local communities with disabilities as experts in their experience without, and this is really critical, right? Without indirectly or directly communicating that they're the ones who are responsible for fixing the problems.
We're also anticipating the release of another important study from our team, led by Dr. Christopher Moreland. This research shows that students with disabilities are less satisfied with their learning environment when they don't have program access. For our audience, program access was first defined by our team by Dr. Karina Pereira Lima as the ability to either have accommodations when needed or to not require accommodations to access any part of the learning environment, curriculum, or clinical training. Interestingly, when students did have program access, it partially mitigated the satisfaction disparity. So I asked Amy, also an author on the paper, to discuss the significance of this finding and how it might shape the AAMC's strategy for developing more resources to support these students.
Absolutely. So I want to say first, my background is in DEI and higher education, though I've been working in academic medicine for a while now. It's interesting to be coming from two different areas that have become so politicized and I would say in a lot of ways misunderstood and under attack. And I say that because so much of what we found in this paper at a high level, as well as, in other work I've had the opportunity to do with you over the past years, has resonated with my experience, as well as the research and scholarship out there on other historically marginalized populations. We've talked about that, but I just wanted to name it again. And that while program access, means something very specific in a lot of ways for learners with disabilities, I feel like fundamentally it means being able to truly participate in learning or whatever the activity is without fear or those unnecessary or exclusionary barriers in place, right? And that's shared across different historically excluded and marginalized groups. In terms of how this will help inform what the AAMC does going forward, it helps us prioritize what's really important to focus on in guidance, resources, learning, all of that, right? And it's clear from both of the articles that you've mentioned that a lot of the challenges center on disability disclosure and accommodations. And how do we create safe and effective policies and processes and ways of doing that? So I would say going forward, we can really focus on getting more information and resources out there about creating transparent, safe processes for disclosing a disability, as well as interactive processes for requesting accommodations. We can also think about different ways we might be able to get more information out about effective accommodations themselves, right? I think the virtual community is a great place for this. Someone can kind of post and say, hey, I have a student who's in this situation. I'm not quite sure what to do. And then hopefully you've got 5 or 10 other folks in there who can jump up and say, well, we experienced this a couple of years ago. Here's how we were able to address it. It's difficult to overemphasize the importance of that peer-to-peer learning, as well as continuing to release or disseminate these different resources and guidance documents and webinars, say, that we're working with you and other experts.
As we continue our exploration of well-being in medical education, it's essential to discuss the concept of intersectionality and its impact on medical student well-being. For our audience, intersectionality refers to how various social identities, such as race, gender, disability, and more, interact to create unique experiences of both discrimination and privilege. This framework is especially important for understanding the compounded challenges that medical students may face. Mytien Nguyen, an MD-PhD student at Yale School of Medicine, recently conducted a pivotal study on this very topic, investigating burnout at the intersection of race and disability. We asked her to share the key findings with our audience.
In this study, we had the extreme privilege of working with the AAMC on understanding burnout risk among a national cohort of medical students. So we examined burnout risk for more than 27,000 medical students who were surveyed in the year 2 of the medical school. So the AAMC sends surveys annually to medical students in the year 2. Examining this extremely large cohort of 27,000 students, we found that students from historically marginalized backgrounds, that is Asian, Black, and Hispanic students, had the highest risk for burnout. We also found that students with disabilities have higher risk for burnout than their non-disabled peers. We also examine intersectionality between students with more than one disability. So students with 2 or more concurrent disability, like someone who has both a chronic illness and a learning disability, for example, were more than twice as likely to report burnout than their non-disabled peers. Importantly, on the topic of intersectionality, we also examined the intersectionality between race, ethnicity, and disability status with burnout risk. And we found that Black, Hispanic, and Asian students with disability reported the highest risk of burnout across all students. So the underlying reasons for this high risk of burnout for our marginalized students are multifactorial. And I think David and Amy has highlighted a lot of those underlying reasons, including sense of belonging, minority tax, feeling imposter syndrome. So in addition to that, we know that historically marginalized students, including Black, Asian, and Hispanic, and our Indigenous students, are more likely to report discrimination and mistreatment, as well as microaggression throughout the medical training. And this extends to residency training and even into faculty as well. So these basically negative experiences during training and during their careers may lead to making it very difficult to find community and a sense of belonging. And for trainees specifically, finding identity concordant mentors, which are critical to build a student's and a trainee's professional identity and a sense of belonging, is very difficult, especially when we have a decreasing lower diversity as we advance in medical training stages. Personally, so I identify as Asian, first gen, and from a low-income background. In entering medical school, I personally faced significant financial challenges, especially when most of my classmates are from higher income backgrounds. And so during undergrad, while I was at Cornell, I gotten used to navigating the balance between working part-time and my schoolwork throughout my undergrad years. So I thought that going into med school, I'll seamlessly transition to working part-time in addition to balancing my medical school responsibilities. However, being a medical student is itself a full-time job. And in addition to family responsibilities, I've always felt this tug of feeling guilty about working part-time, but feeling the necessity of working part-time in order to keep myself afloat and my family afloat financially. So that tug put a significant strain on my mental well-being, as well as you imagine, feeling imposter syndrome that continues to this day. And I expect, as we talked about earlier, I expect to continue until I am well into faculty. And trying to fit in as a student who's working part-time and trying to fit into a predominantly wealthy medical school class was a lot. And over time, I've realized that it doesn't become less taxing, but more so taxing over time. And then there's the medical school curriculum and what it's like to be a first-gen low-income student in the clinical setting as well, and juggling my responsibilities with my family, so outside the medical school and within the medical school training environment. We don't often talk about discrimination that poor students encounter, including not being able to participate in certain medical school activities because of the fees associated with it. But also what really impacted me most was the discrimination and mistreatment I see towards low-income patients from the healthcare team, as well as from hospital administration, and mainly because these patients represent the community that I came from, or they mirror my family, my parents. And so when I witnessed those discrimination, those hit particularly hard and very challenging. So the same goes for when I see patients with disability being mistreated or not being provided the appropriate accommodation to fully access the healthcare. And especially for patients with disabilities who identify as Asian, Hispanic, or Black, because these are basically the community that I came from, and knowing that within the community itself, there's significant disability stigma. But in addition to encountering those stigma in the community, but also encountering stigma in the healthcare workforce as well, is basically encountering twice as much stigma and compounding onto that as well.
We asked Mytien to imagine she has the opportunity to open a new medical school. In that perfect world, what would she create? How would she remove the barriers for students at these critical intersections?
I think that as a student, it was really heartwarming to listen to David and Amy talk about the efforts nationally at the AAMC earlier, from increasing visibility and partnering with the Steve Fund and the National Academy to advocating for disability inclusion in DC. As a student, I think a lot about what medical schools can do. And I think it's critical for medical school to start to recognize that intersecting marginalized identities exposes students to unique challenges in medicine. So for students with multiple marginalized identity, understanding that the mix of both systemic and structural forces that we encounter every day inside and outside of the hospital, inside and outside of the classroom, will look very different. Essentially, that structural racism, as we know it, and structural ableism are not isolated events, but they're reinforcing events. So, for example, we know that from prior research, we know that Asian, Black, Hispanic communities have less access to mental health services than white communities. We know that Black, Hispanic, and Asian children are less likely to be diagnosed with learning disabilities. So when we think downstream that from these disparities that Black, Asian, and Hispanic community face, downstream, all Black, Hispanic, and Asian students from these marginalized community will encounter simultaneously these significant barriers to gaining appropriate accommodation compared to their white peers. So knowing what to ask for, as well as recognizing the rights to ask, as well as having the right resources, both financial and the social network needed to gain access to appropriate accommodation. And because of this, I think that it's so critical what David shared earlier, that we need to care for our healthcare workforce if we want a health country. So at the end of the day, it's important for medical school, and including as well accreditation bodies, to recognize that there are significant inequities currently to the accommodation process for students from historically marginalized backgrounds, which, because of this inequity, will downstream lead to significant disadvantage for these students. And so we need to critically examine these processes to remove all barriers and challenges that students from historically marginalized backgrounds faces in order to create a equitable healthcare workforce for a healthy country.
I really appreciate everything you've said, and encourage programs to really think about how to be inclusive financially, culturally, and with regard to disability inclusion when they're creating these bonding experiences. Because if you miss out on that, you fail to build community, which is one of the things, Mytien, you said was so critically important to maintaining well-being. So David, Amy, any thoughts in response to what Mytien has presented, or David in response to what Amy has presented, or any concluding thoughts on our discussion today?
I should go because the rest of you are authors on this paper, so you can't really comment on it, but I can. I'm the only one on this podcast who is not an author on this paper. So I'm going to give you, Mytien, since I'm sure the thing was basically your work and you have these colleagues who are very important, but we got to give you the main credit. This is a really important paper. And when I look at papers, I'm sort of an applied math kind of a geek. And so I go right to the charts. And I know, Lisa, that not everybody's going to see visuals, but just for our discussion, I'm looking at this figure that shows the adjusted risk ratio. And let me tell you, just from looking at that one subpart of the picture, all the things I got from this paper that I'm congratulating you on, Mytien. First of all, I congratulate you on your excellent co-authors. You know, I had to say that because they're here, so I just wanted to get that out of the way. Number two, you showed the important effect of disabilities on burnout, regardless of the group. So even those who were not in the marginalized groups had steadily increasing adjusted risk ratio of burnout as the number of disabilities increased. And then when you add in the multiplicative effects, like you're talking about the term intersectionality as a social science term, the math piece would be the multiplicative effects of the disabilities plus background. Then the adjusted risk ratios go almost off the charts. And so I think all of those things are important to remember. Disabilities are a critical risk factor for burnout, period, no matter who the person is. And if the person happens to belong to these other groups, then it's even scarier, it's even worse. So I congratulate you on your co-authors, on the paper itself, on the way you set up the charts. Everything was super well done. And you're a Cornell grad, right? Yeah, so I'm proud of you. You did a great job. Great job. You know how I am by Cornell. Anyway, great job on this paper. I think it's just super, and I congratulate seriously all three of you. Very, very important data. And the paper's data rich, and then we can all learn from it. So congratulations on that.
This is an incredible team. And one of the things about our team is that we all rely on one another. But this team in particular is really well informed from both the trainee perspective and from faculty with disabilities and faculty that are underrepresented. And so I just think it's such a beautiful group. And of course, it was led by the amazing Mytien. Dr. Karina Pereira-Lima was also part of this group, as was Dr. Justin Bullock, Amy Adams, Dr. Christopher Moreland, and Dr. Darwin Boatwright. And so I just wanted to make sure to give a shout out, since yes, we are all on this, but we didn't do it in a silo. I mean, I will say 75% of it at least was Mytien. She's an absolute powerhouse. This is not new scholarship. Mytien has been publishing for years. She publishes more than most probably professors at this point, and has an incredible track record of scholarly work in the DEI space. And so if you're interested in any concept of DEI and outcomes, I think you should really investigate her work. She will be, not maybe, she will be an academic medicine star and will outshine all of us. I think relatively quickly. It won't take long, but please do check out her whole body of work. And we're just blessed to have her collaborating with us on the disability front. So we're very proud of her as well, David.
First, I'm going to echo, David, what you and Lisa both said, and continue to sing Mytien's praises. It's always a humbling experience when you have the opportunity to participate in research with folks who you've been reading for years, and whose work you've admired for years. And Mytien, you have been on that list. Lisa is certainly on that list. Darwin is on that list. Justin is on that list. Chris is on that list. All of y'all are on that list.
Amy,
yes,
you're on that list too.
Thank you, David. But it's an amazing and humbling experience. But there are a couple of things, and I'm not a researcher by training, so some of what I begin to think more about is what's some of the programmatic or policy or practice-based stuff that we might be able to do, right? So especially in thinking about the paper that you led, Mytien, it really reinforced for me that importance of not siloing the work, right? With anything that might be kind of lumped or grouped under belongingness, or, what we might call DEI, learners' experiences with disability or with any other marginalized or historically excluded identity don't operate in silos. And so how we address inclusion shouldn't either. And so that knowledge and awareness, I think, really needs to be integrated across the institution and then complemented by those designated knowledgeable professionals to lead specific interventions and initiatives, right? But it's not letting anybody off the hook, because any learner, especially a learner with one or more, historically marginalized identities, is going to be interacting with folks across your entire system. So how do we really work to have everybody prepared to respond and behave in culturally responsive and appropriate ways? And that also makes me think about holistic student support. And Mytien, I know we've had some conversations with you about this, because it's an emerging initiative from the AAMC, but that's really being led by so many of our constituents, by so many of our folks who are working in student affairs, in medical education and curricular and assessment affairs, in student diversity affairs. And it's a comprehensive approach to supporting the overall well-being and success of medical students. And it's really focused on that institutional responsibility for learner thriving. And so much of the particulars that are in that paper make me think about what in our systems can and need to be changed in order to really disrupt and get rid of a lot of those assumptions and really outdated norms and attitudes and behaviors and cultures that are holding these exclusionary systems in place. As this paper makes so clear, that students are bringing these multiple intersecting identities with them. So how do we really focus on creating those systems that are going to recognize those intersecting identities for the assets that they are, not pathologize them, not stigmatize them, not not apply a deficit lens, but really value them for the assets that they are, and think about both those individual and cohort level supports that are going to enable that thriving and success.
Amy brings up an important concept about our systems, that if we're going to make progress on any of the myriad issues that are facing us, we have to think about them at the system level, because you can't count on, individual areas to solve all the problems. But I do want to say that in addition to the systems thinking that Amy brings to this and many other things, there's always a role for each of us as individuals to understand our own implicit biases, to look in the mirror every single day and understand what it is about ourselves that we can be more aware of and bring more thoughtfully to the table. And if we could do that, if we could deal with our own issues and, as Amy said, change the systems, then we really have a chance to move mountains.
I agree. We need individual and systems level change to make this happen. And after listening to you, Mytien, we're all motivated even more to make it happen.
I just want to say what a thrill it's been to be on your wonderful podcast. I thank everybody. You guys are champs. Really, really impressive.
I want to thank all of you for your insights and your contributions. And I encourage our listeners to engage with all of the ongoing efforts to improve well-being and inclusion in medical education that have been listed today. We will certainly include those in the show notes. So Amy, David, Mytien, I cannot stress how much I appreciate all of you and the work that you're doing in your support of this ongoing work in the disability space.
Oh, thank you, Lisa. We'll be waiting like in 15 minutes when you throw this thing back at us to work. You know the way Lisa is, you guys, in 15 minutes, you'll have the whole thing put together, sorted through, edited, and then she'll be tapping her toes.
Guilty.
Come on, let's have your... You know that's going to happen.
This was not only amazing content, it was fun.
This was fun.
Thank you.
It was. Thank you.
Special thanks to Dr. David J. Skorton, Amy Adams, and Mytien Nguyen for generously sharing their reflections on the critical juncture of well-being, race and ethnicity, and disability for our learners. Their experiences as leaders, learners, and researchers add to this rich discussion. To our audience, a sincere thank you for joining us in this episode. We invite you to subscribe to our podcast, and we look forward to having you tune in again. If you're interested in learning more about disability in academic medicine, be sure to check out this month's Academic Medicine podcast, and again in September, where host Tony Gallo will interview the authors of 2 disability-related papers. Additionally, don't miss the Beyond the White Coat podcast with Dr. David Skorton from March 19th, 2024, titled, Why Aren't There More Disabled Doctors? To stay updated on all the work in this area, make sure to subscribe to these podcasts. This podcast is a creation of the Docs with Disabilities Initiative, supported, in part, from the University of Michigan Medical School Department of Family Medicine and Disability Initiative, the Stanford Medicine Alliance for Disability Inclusion and Equity, and the Ford Foundation. The views expressed in this podcast do not necessarily reflect those of the hosts, their respective institutions, or the sponsors. This podcast is released under a Creative Commons Attribution, Non-Commercial, Non-Derivative license, and was produced by me, Lisa Meeks, with the valuable assistance of our audio editor, Jacob Feeman. Thank you and have a wonderful week.